Hi, everyone. Thank you for joining our webinar today on anti-criminalization in practice for public health. I think we're going to go ahead and get started. I'm going to turn on closed captionings real quick for everybody to have. All right. Should we get to start? So hi, everyone. Welcome to our webinar today. My name is Alika Upadhyay, and I am a senior associate on the Drug User Health team here at NASTAD. Thank you all for being here, and extra thanks to Reframe Health and Justice and our panelists for being here, and also Reframe for working on these anti-criminalization for public health systems, resources, and webinars. So just as a brief description, NASTAD has been working with Reframe Health and Justice through the National Harm Reduction Technical Assistance Center to develop resources specific to serving and providing harm reduction services for people who are criminalized, have been involved with the criminal justice system, including people who trade sex and people who use drugs. We held the first webinar of the series on March 16th, and the previous recording can be found here. I will toss the link in the chat in a moment. And the first webinar was a primer and an introduction to anti-criminalization concepts in public health. Today's we'll take these concepts and discuss what they look like in action. There is also an accompanying fact sheets that will be emailed with the webinar recordings in the next week. And NASTAD is able to provide this platform and address anti-criminalization because for decades, NASTAD has been a national leader in the fight to address HIV criminalization and laws, policies, and practices that unjustly sanction people living with HIV/AIDS by criminalizing exposure and transmission. Recognizing that these laws are stigmatizing, discriminatory, ineffective, and serve as barriers to testing, prevention, and treatment goals. Beyond HIV, we recognize criminalization and punitive responses to behaviors such as drug use and sex work, and wanted to make space to examine the different ways criminalization manifests in our work. Additionally, we know that racial and ethnic minority groups such as Black, Latinx, and Indigenous communities have faced increased criminalization due to systemic biases in policing and incarceration and have been disproportionately targeted by the war on drugs. We know that health departments have limitation in advocating for legislative and policy change and addressing criminalization directly. However, we must recognize criminalization as a structural determinant for health for the communities that we work with. Our obligation to those communities is to find creative and practical strategies to disrupt and dismantle criminalization and build more compassionate, equitable, and effective systems. So today's session is an opportunity for peer-to-peer sharing of successful and promising strategies, which public health agencies and professionals can influence. So thank you all. I'm gonna pass it over to Kate to kick us off and take us through the webinar.
Thanks so much, Alika. I'm Kate D'Adamo. I'm with Reframe Health and Justice. And as Alika said, we've had the privilege of working with NASTAD over the last several months to develop fact sheets. And this is the second of two webinars exploring the issue of anti-criminalization for public health. And I'm just going to share a quick couple of slides here just to ground us. So today we're going to go even deeper from our last conversation about what anti-criminalization looks like for public health departments and folks working in public health. And just for some quick initial housekeeping, first off, we ask everyone to turn off your videos and set your microphones to mute. The videos really help support the bandwidth as people are watching this. We ask everyone to please put your questions in the chat until Q&A. We're going to get to Q&A at the end. And then if folks want to come off mute to be able to ask their questions, that works. But in the meantime, if you put them in the chat, we'll have someone monitoring the chat to be able to catch those as they come in. Next, we're just asking everyone to be open to learning and to growing. A lot of this information, we're really excited about this panel today, is going to be talking about some of the ways that especially our public health departments and our organizations and us as community and peers are trying to support criminalized populations. And it's important to be open to all of the things that are being shared. And lastly, this will be recorded and will be available on a standing page on NASTAD NASTAD's website, and you should be receiving an email next week for signing up for the webinar with some materials and a link to the recording. So first off, I just want to give kind of a very quick primer on what we're going to be talking about today when we talk about anti-criminalization. The link that's going to go into the chat, or is in the chat, or I'll throw it in the chat, is to the previous webinar, which explored the concept of anti-criminalization for public health and communities, and why it's so important to improving health outcomes for everyone, and especially essential to understanding health equity when it comes to especially racialized communities and other policed individuals and community spaces. So I'm just going to touch on some quick notes and encourage everyone to really watch and read from last time to get a deeper sense of what anti-criminalization is talking about and why it's so important. But just to ground us in this conversation, first and foremost, it's important that when we talk about criminalization, we talk about it as broadly as it is to understand the full breadth of how it impacts not only criminalized people or people engaged in criminalized behaviors, but also criminalizes the ways that we try to improve public health overall. And so criminalization is the process of turning actions into crimes. And that sounds broad because it really is that broad. When we think about behaviors that are criminalized, they really encompass a full range of behaviors to things that, you know, we can definitely culturally agree upon as behaviors that we want to sanction, all the way to a lot of the behaviors that you're going to hear about today, such as substance use, trading sex, being pregnant, as well as having those experiences and being supportive of people in those experiences. And so when we're talking about the behaviors turned into crimes or the actions turned into crimes, that includes health interventions very often. And criminalization is also the process of turning people into criminals. And that's really important because, you know, we can talk about the impact of policing and the way that it shapes behavior, but it also shapes the way that people interact with different systems. And that goes far beyond when we think about the criminal legal system, when we think about policing and arrest and incarceration. We also need to think about all of the different systems, including health and welfare systems that are impacted by criminalization and that are very often asked to participate in criminalization as within partnerships with other with institutions like law enforcement. And so the process of turning people into criminals also includes peers and service providers, and it also impacts the ways that people engage with different systems, including systems outside of our traditional understanding of criminal legal systems. And we touched on briefly the impacts, and especially the impacts on health outcomes during our last webinar. And this really happens in a number of different ways, and talked about it in different stages. So first and foremost, policing of people who know that they are criminalized impacts behavior. If we're talking about substance use, it might cause people to, if they are injection drug users, it might cause them to use faster because they want to be out of the public eye. If you're talking about people who trade sex, you're talking about if people work in public spaces, shortening their negotiation times because they're afraid they're going to be policed and seen. And so long before anyone is caught up in the legal system, in the criminal legal system, they're often still already changing their behaviors and compromising the potential for harm reduction interventions in order to meet their needs. Second, when we talk about arrest and especially initial incarceration, we can very easily think about the ways that for someone who is a substance user, for someone who is pregnant or has other kinds of health experiences, that even the process of simply arrest and waiting, being held before booking can have really significant health impacts. Access to medications, access to other substances no longer are on the table. During incarceration, these are periods where we know that incarcerated people and people under state surveillance experience incredible forms of physical, emotional, interpersonal violence, as well as lacking access to care very often, lacking access to supportive care for whatever health experiences they're having. And then finally, upon reentry, we know that connections to care are incredibly hard. Even when people are coming from an incarcerated system, you'd think it would be easy to know that they're going to be able to access benefits, but we know that that is simply not the case. Connection to care is very difficult, and in some places, depending on your charge, for example, if you have a drug-related felony, you might have to wait before accessing SNAP benefits or food security, or you might be prevented entirely from accessing forms of support and care. In addition, we know that people coming out of incarceration facilities are already experiencing the ramifications of incarceration and experience incredible forms of risk, not just in terms of access to things like housing or other social benefits, but the impacts of being incarcerated and coming out, and for example, accessing substances again can have significant impacts. And in some places, people are 40% more likely to overdose in their first few weeks out of an incarceration facility. And so the impacts of criminalization and policing are very, very, very widespread for communities. But what we want to talk about here and today, and I'm going to stop sharing my screen, is that not only does it impact the health outcomes of the communities that we're talking about, it also has really important impacts on the ways that we attempt to serve those communities, and often compromises our ability to do so. And so I'm really thrilled. I could not be more excited about this panel, to be perfectly honest. I can't wait for this conversation myself. And so today we have three amazing panelists who come from different areas of working with criminalized populations around access to care and access to health equity. And today we are very excited to put these incredible folks in dialogue with each other to explore this issue and to explore why it is so important that public health departments and folks working in some way that impacts health equity, how there's how the experience of criminalization is something to navigate and something to navigate around in order to provide care. And so just to introduce our panelists, first we have Indigo Hahn. Indigo is a caregiver, community organizer, sex worker, and harm reduction practitioner. They settled in Osage Land in St. Louis City in 2015 and led the St. Louis chapter of the Sex Workers Outreach Project to 2018 to 2019. Then they co-founded Moho Justice, which is a coalition based in St. Louis in 2020. They are currently serving as Moho Justice's Healing Justice Programming Lead, and they also work at the T, where they support mobile outreach, opioid harm reduction, spiritual care, and wound care for people who use drugs and bullet injury survivors. We also have Charles Hawthorne. Charles manages California Bridge's equity and harm reduction work. They joined California Bridge with 4 years of harm reduction education and program development experience as a capacity building manager at the National Harm Reduction Coalition. Charles joined California Bridge to advocate for higher quality emergency services for people of color who use drugs. Charles has a BS in biochemistry from Purdue and an MPH from Johns Hopkins University as a Bloomberg American Health Initiative Fellow in the addiction and overdose focus area. Last but certainly not least, we have Mahathi Vemireddy. Mahathi is a legal fellow at Pregnancy Justice. Pregnancy Justice is a nonprofit legal organization dedicated to defending the rights of pregnant people against criminalization and other rights violations because of pregnancy and all pregnancy outcomes. They are also a recent graduate of Northeastern School of Law with a concentration in health law and policy. She previously interned at the National Institute for Reproductive Health, ACLU's Women's Rights Project, and Pregnancy Justice, and it is genuinely an honor to have these folks here. And I'm going to start with a question, and I'll start with you, Indigo. This is one of my favorite questions. What is one takeaway that you would like our audience to leave here with?
Thanks, Kate. I would want our audience of folks who are movers and shakers in public health to recognize how criminalization is directly antithetical to public health, both like the work they're doing and just the health of the public, in the sense that health weaponized against crisis communities as a way to influence, excuse carceral violence, and stigmatize people and behaviors to, as you said, worsening outcomes, and that to really, and it becomes like a red herring for like the real issues that we need to be addressing in our communities, by and large, to promote better health in our communities, especially the most marginalized folks. And just recognizing how I hope that throughout this discussion, folks will leave with an understanding of how that really especially impacts sex workers and people who participate in outdoor and informal economies. That these are all just members of the community, and they are part of our community. They don't need to be seen as separate or as criminals.
Thank you. Charles, how about you?
I feel like I'm probably somewhere pretty similar to Indigo, but maybe on like the opposite side of thinking about how doing decriminalization work is actually an incredible opportunity to do really great public health work. I think that I got my start I started in harm reduction, I would say, before I became a public health practitioner. And I think what I have seen time and time again, and especially in seeing the differences between how my colleagues in the harm reduction space and my colleagues more in the formal public health space do their work, is I think that there's a lot of tools that we can get from decriminalization work, especially when we think about all the ways that decriminalization work pushes us to center people most impacted, to listen to them, to communicate and have multiple streams of communication in multiple directions in order to learn from them. What we result in is having data and having information and having an understanding that allows us to actually do much more quality community health work. And so learning what it looks like to practice it from a decriminalization lens can actually make you a much better practitioner when it comes to your work.
Thank you. And Mahathi, what is the takeaway that you'd like everyone to leave with?
So the takeaway that I really hope everyone leaves with is that pregnancy criminalization only deters pregnant people from seeking vital care and communicating openly with their healthcare providers. Access to healthcare services, whether they're abortion-related, perinatal services, substance use treatment services, mental health services, are all absolutely essential for pregnant and postpartum populations. And when we interpret the laws, or when we act with these populations, particularly pregnant people who have substance use disorder, in sort of these like paternalistic or hostile ways, we're absolutely not working towards the betterment of patient care and treating the people that we want to serve as already criminals for just doing the process of going to the doctor to seek care. That itself is being something that people are more and more afraid to do now. And it makes serving these populations incredibly hard when we don't have that confidentiality and mutual trust between patients and providers.
I really appreciate that. And what I loved and sets us up so well for our next question is every single one of y'all talked about how anti-criminalization work is essential to offer care meaningfully. Not only does criminalization affect populations, it also really compromises the way that we are able to offer support and service and the way that people are able to access it. And so, Charles, I'd love to start with you. Can you talk a little bit about what areas of criminalization you usually encounter in your work, especially because everyone works in overlapping areas? And how does criminalization affect specifically the work that you're doing?
Yeah, it's actually really interesting because between our prep meeting and this call, I've actually gotten a couple more examples. But I work in emergency departments mostly. So I work California Bridge as an organization. We directly support 278 hospitals across the state of California with implementing substance use treatment programming. What that looks mostly like is prescribing buprenorphine, which is an opioid agonist that people can take as a way to stave off cravings from opioid use disorder. And also doing things like naloxone distribution and syringe access in the emergency department, as well as part of the work that we do is actually fund substance use navigators to be able to support people in getting connected to ongoing care. So what that might look like is someone comes to the emergency department because they had an overdose, or because they're really sick, because they're in withdrawal, or maybe something else happened to them and their drug use is just coming up as a part of the visit. And instead of just, historically what the emergency department has done is nothing, is just like, yep, we'll give you some fluids, we'll get you stabilized, and and then we just kind of kick you out. And now what we're able to offer through this bridge program is we can actually we can start you on substance use treatment immediately, and we can make sure that there's a person who is connecting you to care. But there's lots of times that criminalization just makes it really hard to do this work. So for example, I think one of the examples that has been coming up recently is there's been some examples where patients have been denied care because of their substance use, because of arrests or other things around substance use. So for example, a patient had come in because they had had an injury. This patient had had a prior visit to the emergency department for an overdose that was marked in their chart. And because of that, when they came in for this injury, which was a leg injury, which they had hurt their leg, this patient was denied pain management medications because these the medical providers at this space saw that on his chart and decided that this patient was an addict and was just coming here to get medication, or just coming here to get pain pills, and did not want to get him to adequately treat his pain. What that resulted in is that patient literally just leaving the hospital with a massive injury on his leg because he could not deal with the pain. And the only way that he knew how to handle the pain was to go out and purchase substances on the street. So literally, this is a moment where something has nothing to do with this person's substance use has resulted in them getting subpar care and leaving the emergency department against medical advice, because of the way that these physicians and these care providers in the hospital have criminalized their substance use. There's also a whole thing that's going around right now around people having drugs in the emergency department. So there's some multiple examples, and there's kind of the way it's come up in a few different systems around the issue of, what do you do if you find drugs in a patient's room? What happens? And usually what happens is they call the police, which means a lot of the times when patients who have come in their own personal belongings, they have their own substances, and a nurse finds them, or they're searched when they're being admitted into the hospital, or whatever the situation kind of is, they find substances. And what could happen is, if that patient is at a point where they're stable enough to leave the hospital, that patient could be discharged directly into custody of the police when they came to this hospital to access medical care. Or what it might result in is them being put on a sort of bed arrest with a police officer while they're in the hospital. Which, if you think about it logically, we are all people who have gone to the doctors. We have all gone and had the doctor ask that question: how many drinks do you have in a week? How many times do you smoke? How many things do you do this? And we all kind of do that math in our head of, how many do I do versus how many do I want to tell this doctor that I do, in order to not get in trouble, in order to not have that on my chart, in order for them to not judge me, or maybe prevent me to getting other certain types of care later on. How do I kind of handle that? And when you're using substances that are even more criminalized, that math, the results of the math become even more dire. And so when we're put in a position, when medical providers are being put in a position, and when patients are specifically being put in a position where their substance use or their possession of substances could result in them just being arrested, it does not encourage them to be honest about their drug use. It does not encourage them to actually want to talk to their provider and give them the information. And that's the thing. The thing that doctors talk about so much is really the role of a physician is to be a detective. You're supposed to be there to learn, to gather evidence from this person, to work with your patient, to get all the information that you need in order to provide them the highest quality care that you can. And criminalization cuts a conversation stream off. It says, this is a thing that I cannot talk about. This is information that I do not feel comfortable giving you. This is data that I cannot offer, because what that might result in is actually worse care or a worse life experience for me. And that hamstrings providers. It stops them from being able to do the things that they want to do. And of course, there's a lot of providers who also have a lot of stigma and absolutely exacerbate the system. And there's a lot of providers that feel very stuck in it, where they're like, I don't want to lose my job because I didn't report this person. for having these substances. And I also recognize that when I report this person for having these substances, it's going to destroy any rapport that I've managed to build with this patient over their time there. And it just doesn't, it's not smart. It's not effective. It's not good medical care. And when we take that and multiply it on the community scale of how many people are coming into the hospital, of how many people are accessing this care on a regular basis and are not being able to feel like they can be honest with their drug use, about their drug use, it just results in a really wide spread of people not getting the care that they need.
Thanks so much for that example, and really concretizing how this more insidious forms of criminalization. That's such a great point. And Mahathi, I have the same question for you, and especially, you know, considering that a lot of this is kind of in motion in your field. Could you talk a little bit about how criminalization is showing up for folks and how it has shown up for folks that you work with?
Yeah, absolutely. So I think one of the really important things to understand about pregnancy criminalization is that it's not new. It's not since just the fall of Dobbs. So pregnancy justice, through legal advocacy, public education, research, and organizing, we seek to minimize the harm of the criminal legal systems and family policing systems to keep families together and prevent other forms of state violence. And that's because since the 1973 Roe ruling, which established abortion and gave basic reproductive rights across the country, pregnancy justice has already documented about 1,700 cases where pregnant people have been arrested, prosecuted, convicted, detained, or forced to undergo medical interventions such as cesarean surgeries because of their pregnancy status or outcome. And there is like a myriad of different laws that have allowed this to happen. The one that would most come to mind is abortion bans because they're so prevalent in the news, but there's also feticide laws, fetal personhood laws, child endangerment and abuse laws, chemical endangerment and minor laws, all of which particularly target pregnant people with known substance use disorders. And for context, I don't want to be too legal about it. Fetal personhood is basically this legal doctrine pushed by anti-choice groups that basically suggests that fetuses have the same personhood, have the same right to legal and protections and rights as a pregnant person. And when providers are put in this position where they're trying to decide what's in the best interest of the pregnant person, these laws that are coming into effect are basically asking providers to treat the interests and needs of a fetus and the interests and needs of a pregnant person as dual rights that are constantly in opposition. This means that pregnant people are not being given equal care. It also means that pregnant people are more likely to be reported to state agencies and law enforcement if they have done something or admitted something during prenatal checks that a provider thinks might be harmful to the fetus. So we've had one case in the past where someone has failed to wear a seatbelt while pregnant and got into a car accident, and that's resulted in a criminal case. We've had cases where people have very responsibly, very appropriately informed their care providers that they have substance use disorder or they had substance use disorders in the past and are seeking treatment or such as medication assisted treatments for their substance use, which is 100% safe to do. And instead of receiving that care, they are then being reported to either CPS or the family regulation system in the state, or they're being reported to police as a form of child abuse because the child through in utero exposure is also being harmed by the drug exposure, even though, as we know, that's not necessarily the case. We've also had cases where people have used certain controlled substances during their pregnancy, such as methamphetamine, and have had a pregnancy loss, whether it's a stillbirth or a miscarriage. And those cases are now being brought forward as either manslaughter or homicide charges against a pregnant person, even though pregnancy loss is unfortunately a very real reality that may have multiple explanations or causes, and that cannot necessarily be directly caused by drug use. But law enforcement and many legislatures at this stage are unwilling to look at that science and are just seeking to criminalize pregnant and postpartum populations through these laws. And the way that public health providers are particularly important to our work is that about a third of the cases that we have documented since 1973 have started because a healthcare provider or another helping professional has reported to the state or another state authority that a pregnant person has conducted some behavior, has used substances, has not worn a seatbelt, has done X, Y, or Z action. And this is particularly through drug testing and reporting laws that exist in these states, which have, because of their constantly changing nature, has led to healthcare providers over-reporting pregnant people and not engaging them in their own healthcare. Basically, healthcare providers in a lot of our cases have just become another arm of the state to continue violence against these populations that absolutely deserve and need essential healthcare services.
That's such a fascinating through line that you and Charles both talked about how not only kind of one of the complications is like not disclosing, and then disclosing also then forces people to participate in criminalization of those communities as well. And Indigo, I would love to hear how criminalization is affecting the folks that you work with, and especially how it's affecting the work that you're doing and the way that people are accessing support and care.
Yeah, there are a number of different dimensions to the ways that criminalization impacts both the folks that I interact with on a primarily like opioid use harm reduction basis, as well as in sex work community. I think that it's really interesting how a lot of the issues that we see in both cases overlap, but also there are a lot of distinctions, which really point to how important it is to really be in community and aware of like the specific impacts that criminalization have on different populations. So just to like refresh, my background is doing street outreach that is centered around people who inject drugs, as in my like day job, as well as with sex workers. And I do street outreach for sex workers, sometimes at the same time, honestly, as the other kind of work that I do. So population, we find, is very much like the Venn diagram is mostly in the center, because the numerous locations that Moho Justice conducts our street outreach on are actually the same locations that I have done street outreach with the T. The T's target population, or most centered population that they work with, are Black men. That is because in Missouri, in the last 5 years, the overdose rates for Black men have increased 500%, and that's a disparity they've just far separated from the pack between Black women as well as white men and white women. And so there was a lot of funding around targeting areas where Black men were most likely to be around and at risk of overdose. And in sex worker centered spaces, we do interact with men, but there's a gendered aspect of it too, where most people that we see are Black women. And that is, it's not that their issues or concerns are necessarily different from a lot of the Black men that we serve, because Black women are also needing safer injection supplies. Black women are also needing housing that we see, but because of the way that the data is, that's how the funding is. And so a lot of the existing interventions were around syringe access. But in reality, we see that Black women that we work with and are in community with are criminalized on multiple aspects of what they do to survive and their identities. And we see that show up in the way that some of our interventions and the criminalization of our interventions play out. So we'll be at the same location, and the T may be addressing safer use supplies and resources distribution. MoHo, the sex worker oriented group, may be distributing condoms, safer sex supplies, menstrual hygiene supplies. And we're seeing the same people, but we see that the people who do sex work are criminalized in different ways and in almost like compounding ways. So we may have a STI HIV partner around as well. And for people who are simply engaging with us as a person who injects drugs, may take an HIV test, may find that their HIV test is positive, and will be immediately linked in to services. And this can be viewed sometimes as almost like a unfortunate golden ticket, in that it opens up access to specific HIV related resources. Robert White kind of funded housing resources, treatment resources that otherwise wouldn't be on the table. But if you have somebody that trades sex, things get a little bit more dicey, because then they may be at risk for sentence enhancements. In Missouri, prostitution is a Class B misdemeanor, unless you know that you are living with HIV. Even if you use a condom, even if you do all the right safer sex practices with a client, knowing your status can mean that you get charged with a felony instead of a misdemeanor. Or if you are repeatedly picked up, arrested for prostitution, you may be subjected to enforced HIV testing, whether or not you consent to it, as a condition of your bond. And so we actually, as a harm reduction practice, do some kind of disclosure coaching with sex workers who may be interested in getting tested, because knowing your status is important, and people who trade sex know this probably more intimately than civilians, because our bodies are our asset in our work. And many workers may want to know their status, but are concerned that all these forms that are given by the health department, the state, ask all this very invasive information, and their status could get reconnected to them. So we actually, as a harm reduction practice and as kind of doing public health and action, sometimes we help workers understand exactly what they need to say to fill out the form and get their services, without it being identifiable, without it being able to be traced back to them, which can also lead to somebody not being able to get plugged into the services that they need, out of maybe having to make that calculus of, I need this one thing to protect my health, but my health is also going to be pretty bad if I'm in jail. And I know that's not a safe place for me. And we see this also happen with housing services, where some people may be really wanting to access certain kinds of housing assistance, but because they have a arrest history for prostitution, or may be known as somebody who has done sex work, their opportunities to access services, women's shelters,
things of that nature in terms of accessing housing can be restricted as well because of people who are trying to provide access to housing not wanting to take on the liability of potentially being like charged with some sort of trafficking related offense. And we see things similarly play out when it comes to facilitating access to medical treatment. We are really blessed to be able to have resources to support people's transportation to and from a treatment facility at my day job. And that is offered and provided without even question or a second thought when somebody needs that for addiction recovery purposes. At Moho Justice, we are also struggling with trying to support people who need to access out-of-state reproductive health care, sometimes related to their participation in sex work. And the issue of transportation. A lot of people don't have great transportation options, and there are federal laws that actually, go back decades. The Mann Act, for example, that criminalizes federally the transportation of somebody doing sex work across state borders for immoral purposes. And as we see with the criminalization of abortion, that's very much being framed as a moral panic issue. And that becomes a barrier for us to be able to facilitate access. And we also see that in the approaches, between reaching people who use drugs and offering harm reduction supplies versus sex workers, it just tends to be a little bit more relationship based with sex work. Oftentimes we focus on more immediate resources and services that people who use drugs, especially people who inject drugs, need to just make it through. Things like safer use supplies or wound care pertaining to kind of surface skin wounds related to drug use. But with sex workers, oftentimes the bigger harms that they're dealing with is navigating systems of surveillance surrounding their work and interpersonal harm. And so we focus a lot more on relationship building and community knowledge sharing to be able to navigate the bigger and more sometimes more immediate pressing concerns that sex workers have pertaining to their health. How do I safely defend myself or get out of a moving car when a client's trying to attack me? How do I negotiate my services better? How do I advertise in a way that doesn't lead to the police conducting some sting operation at my place of working? And those are really just insights that exist oftentimes in community and are only trusted within community. And this gets even trickier when we have more federal legislation like FOSTA SESTA that criminalizes the capacity to host that on a web-based platform that would make it more accessible to more workers and fold more people into these kind of community safety, community harm reduction practices. So oftentimes there is so much overlap because the needs of many sex workers are congruent with the needs of people who use drugs, and we see oftentimes the same people in both contexts and serve them in similar ways. But the compounding forms of criminalization, especially for sex workers who use drugs, make the process of that a lot more complicated and much more an ongoing conversation and relationship building dynamic rather than here's your stuff, and here's the Narcan, and let me tell you how to use it, and now you're good to go.
Thank you so much. And you brought up so many points that we're gonna revisit. And one of them, and when you were talking about, you know, how people are viewed by the system differently, Charles, a lot of your work focuses specifically on people of color that use drugs. And we know that criminalization is a very racialized and a very gendered project. And so how does taking a racial equity lens around anti-criminalization impact your work?
Yeah, I mean, I think that the main thing that I always have to kind of stress is our entire network of criminalization is like birthed from chattel slavery. So there's a lot to kind of, and it's like a very jarring thing. And I think also it can feel a little buzzwordy. It's like, yeah, everything comes from slavery in this country. And I think that there's a reality in like, yeah, it does. And I think it's important to kind of think about, how are you in your role furthering the mission of people who have done the hard work of transforming chattel slavery into our modern criminalization space? And I think for me, it thinks about like, how are we all acting like cops? How are we all pushing and furthering these same dynamics that have existed in this country since essentially its founding in our modern sense of America? And so I think about when I'm doing a lot of this work from a racial equity lens, well, a lot of it is about remembering, and I think that the way that Indigo kind of set up their story told a lot of that, of like every single thing is like another goddamn barrier. It's like, I would love to go ahead and just take you across this state so you can get this state line so you can get this, but that's a law that I'm going to be breaking. And I'd love to put all this information up on the internet, but we're going to, FOSTA SESTA is going to get it taken down. And like, it's like a lot of those things. And so really thinking about how do you have to kind of show up as an accomplice in your work is really the big question. And so I think that a lot of the times where I kind of center for people is starting by thinking about like, well, what resources do people have and why do they do or not do them? And so, for example, I actually got my start in working in harm reduction, actually in sex work as well, working at HIPS in Washington, D.C., which is a incredible program. And most of the clients that we work with are Black trans, that we worked with at the time were like Black trans women. And a lot of the exact things that Indigo was naming of these compounding issues that kind of are like, yeah, people who use drugs and also trade sex and are also Black people and are also women and are also trans, where all those things kind of add together to kind of create these multiple layers of harm. And I think a lot of the times what it might look like is, okay, maybe police are coming and doing sweeps. And when the police write their press release about these sweeps that they did, they're going to be writing about, oh, we came and we picked up all these people who are doing prostitution on the street and we made your neighborhood safer and we did these things. When in reality, what this was a racist operation. You came to an area where there was primarily Black trans women working and you arrested them. And that is nothing different than any other forms of arrest that police do. I think about how in San Francisco, in the Tenderloin area of San Francisco, which is the area where there is a lot of drug use and drug selling that happens, there is a large network of mostly South American young men who are doing a lot of the drug selling in San Francisco. And there are regularly operations where police will come through and arrest a lot of those people. And and of course, it's the same thing. We're taking these drug dealers off the street. We're doing these things to make a community safer. When really the reality is San Francisco is a sanctuary city from ICE. Immigration officials are not able to conduct operations within the city, and arresting these people is essentially an ICE operation that's happening under the guise of drug use. And I think that where it always comes back to me is people have been fucking for a really, really long time. People have been having sex, selling sex, and buying sex for a very, very long time. I went to Pompeii in the 7th grade in Greece, and there were advertisements literally cast in the stone of the lava for people selling pussy. Like, that is the reality of our world. People have been using drugs for so long. They find evidence of people having coca and poppies and all types of things in the bone and skin and teeth and hair of people for thousands and thousands, tens of thousands of years. None of this stuff is new. It just isn't new. But what happens is when people moralize it, when they flip it, and when they make it a bad thing, what they're actually able to do is to use it as a proxy to actually take down the things they want to take down, which is movement work, which is people rising up against capitalism, which is people having an issue with our imperialist system. And with us large, and that's really what we're talking about. We aren't even talking about drugs. We're not talking about sex. What we're talking about is systems. And when you really take a perspective of racial equity, of gender equity, and you really start to point that out, you see how none of this is really about the sex. Pretty Woman came out, I don't know how many years ago, and we're not talking about that. There are people who are selling sex in every hotel bar in your city. There are people who are selling sex on the internet right now, all types of ways. But the difference is the people who are being criminalized and the people who are being arrested are the people who are bucking against the system racially, people of color, Black people, Latinx people, especially, and especially in growing, especially out here on the West Coast, East and South Asian people especially. And along with that, people who are bucking the gender norms. So trans folks are really the people who are bearing the brunt of it. When it comes to drug use, there are, a question I ask a lot in harm reduction trainings, I'll go to people, and you can think about this too, is do you think that every person who injects heroin in your city is homeless? And everybody's like, no. And I'm like, do you think that every person who injects heroin in your city makes less than $50,000 a year? No. Less than $250,000 a year? Absolutely not. There are people in every one of these expensive high-rise buildings making millions a year who do the exact same thing. The difference is they have the resources to buy higher quality substances and to use them in their own safe environment, which a lot of other people do not have. And those are the people who are really being criminalized. And the reason they're being criminalized is because when we see those people on the streets, it's our reminders that we better show up to work tomorrow. We better do our thing. We better do the thing to keep this whole ball of capitalism rolling, because trust and believe it could be any one of us on that street tomorrow getting arrested right next to them. And that's the thing that they want you to forget. That's the thing that they're really trying to get us to move in line, and not just think about it in the perspective of, they don't want us to think about the drug. They don't want us to think about all that stuff. They just want us to stay laser focused on the drugs. And really where the power is when we decenter the drug use, when we decenter the sex work, and we really start to think about how are we promoting health? How are we creating a world that isn't rooted in sticking our head in the sand and pretending like things that have always happened are just going to suddenly stop one day? And instead of reframing it and re-putting it in a perspective of how am I going out every day and doing my work in a way that is going to help someone be healthier, that is going to help someone be safer, that is going to empower them to make choices that work for them. Because ultimately that's all we can really do is empower people to make choices that work for them. And how do I clear away as many of the barriers as possible that are stopping people from being able to do that every day? And that is really what rooting your work in equity looks like.
That is beautiful. Thank you so much for really grounding us in not just an understanding of criminalization's impact, but what criminalization really is. And I so appreciate how you were talking about how criminalization is about an excuse to go after certain bodies in certain spaces, and the law becomes kind of secondary. It's a tool. It's not necessarily the outcome. And that reminded me, Mahathi, of what you were saying around the person who wasn't wearing a seatbelt. Like, how many of us have not worn seatbelts? And the idea of what happens because you are a specific person in a specific body, how different that is, I think really is underscored by what everyone is saying here. And I want to go to you with the next question, especially because building off of what Charles saying, that like criminalization of some of these things is ridiculous because these behaviors are ancient. You're in a field that is getting a lot more attention now around criminalization in particular, and is really being hit with just a flood of new laws on a regular basis that are criminalizing things that other spaces have talked about around crossing state lines and posting information on the internet. And so knowing that it's being talked about in this new way, how are these new laws impacting how people are able to offer care for patients, especially as these new forms of criminalization, and please correct me if new is the wrong way to describe them. Yeah, how is this I guess new attention and the new laws that are coming out of it shifting how care is able to happen?
Yeah, absolutely. Thank you for the question. It's a really good one. So one of the things that I want to reemphasize, I mentioned it a little bit earlier, is that these kinds of attacks and forms of pregnancy criminalization are absolutely not new in this country. Charles spoke on it a bit, but these things have been happening. Forced family separations have been happening. Regulation of people's bodies, people's children, what people can do with their bodies and children, and how and when they can have them, are things that have absolutely been controlled by white cis hetero patriarchy for as long as this country has existed. That is absolutely true. So when we talk about this as a new area of criminalization, it makes me always think back to the last time this has been a big deal, which was the crack baby epidemics that happened during the 1970s and 80s, where lots of misinformation about what happens when certain pregnant people, particularly Black pregnant people, use drugs during their pregnancy, and how somehow this has sort of become this wave of we have to regulate, we have to survey, we have to target pregnant people who use drugs and who use substances, specifically because it causes irreparable harm to children. That's absolutely not true. The science does not back that up as a real claim, but somehow it's found its way into all our laws across all our states. In Wisconsin, to this day, there's an act called Act 292, which allows state agencies to civilly commit pregnant people if they have suspected or known or a history of substance use, which means that they can be detained without the protections of the criminal legal system, however insufficient that they are. So the child will be given an attorney, the fetus will be given an attorney, the fetus will be given rights, the fetus will be given protections, but the person carrying the fetus is completely isolated in the situation. They are not given an attorney. They're not given access to counsel. They are held, and if they choose not to be held, then they are committing a separate crime, which is contempt of court. So we have these systems in place since the 1970s that have allowed different state agencies to intervene. And I think that there are specifically two areas within this abortion conversation that have shown new trends or new ways that the right has become really creative in terms of surveilling and criminalizing pregnant populations. The first is around the situation of self-managed abortions. So self-managed abortions, as we know, are safe. They are a safe way of having an abortion. However, to get around the fact that self-managed abortions are safe, there are certain states and certain prosecutors within these states that have used different criminal charges to further penalize pregnant populations. So in the law, typically there are certain crimes that are considered to, certain criminal charges that come in addition to things like homicide or murder that are now being used in isolation to target people who have self-managed abortion. So let me give you an example, because I know that sounds complicated. So in cases where someone might have had a self-managed abortion or might have experienced a pregnancy loss, such as a stillbirth or miscarriage, there is a question that exists in the law about what to do with the fetal remains. So there is a question about what happens now that you have had your self-managed abortion. You now have these fetal remains with you in your home. Criminal prosecutors are now charging pregnant people for abuse of corpse or tampering with evidence in a criminal trial for simply doing something that is legally available to them. And these charges are typically associated with homicide charges, but rather than being charged with the homicide, they're being charged with these collateral criminal charges instead, as a way to kind of get them under this realm of surveillance. We also have cases where states are now moving away from the criminal carceral systems and using the family regulation system as another means of punishing and shaming pregnant populations. So I think a really mainstream example that has come up recently is that parents who support their trans children in getting gender affirming surgeries and care are now being charged with child abuse. And in some cases, pregnant people, even before a child is legally born, are being charged with child abuse for using substances during their pregnancy. There was a statute in Tennessee, I want to say back in 2014, 2016, during the Trump administration at some point, the numbers are hazy, which basically created a new criminal charge, which was known as chemical endangerment, that was used against pregnant people who went to their healthcare providers and said that I have issues with substance use disorder, I would like treatment, I would like care, I would like support. And instead of receiving those things from their healthcare providers, they were instead turned over to CPS, turned over to the police, and charged with this criminal crime. And the state was not ready for it. They were unable to maintain the level of incarceration and the kinds of maternal, parental, and child harm that these kinds of laws created, because they made people very, very afraid to go and get healthcare. So there were more complications, more high-risk pregnancies, more maternal and fetal harm that was being caused by these laws that were meant to protect pregnant people and to protect children, that the law had to be sunsetted back in 2016 or 2017, one of those years. So we have seen these laws come and go over times. And the real way that they have impacted providers is that providers are now incredibly nervous about providing care in ways that do not incur criminal liability for themselves or affect their ability to practice with their medical license in that state. So I mentioned briefly before, but providers are also put into this really difficult position because there are in every state mandatory reporting laws that do exist where providers do have to report pregnant people for substance use because of federal legislations that exist called Capta Cara. So there are specific instances where providers are forced to do this kind of carceral surveillance of their pregnant patients. And because there's so much uncertainty, that leads to reporters over-reporting just to avoid incurring any kind of criminal liability on themselves. And in some of these cases, it leads to situations where healthcare providers might not even tell their patients that they are going to collect this kind of medical data on them through urine testing, through biological testing, before they even report over to CPS, which creates this another layer of like distrust between patients and providers that prevents patients from being honest and prevents providers from adequately treating their patients for whatever mental health or physical conditions that might exist. So we've been seeing these new laws have been creating this kind of panic in these ways. And also, it's also been leading to kind of, I don't want to say a funneling out, but that providers are incredibly scared to practice in red states and abortion ban states. They are now leaving those states to practice elsewhere, or they're retiring early. And these states that we know have really inadequate healthcare access are now just having fewer providers overall available to patients to treat healthcare, reproductive care related services, but also all healthcare services. It's becoming more difficult for people to fulfill their residencies and or professional requirements in order to practice or be licensed in these red states where abortion bans have been put into effect. So it's not only that providers may be forced against their will to comply with these kinds of criminalization practices by the state, it's also that patients, even if they wanted care, if they were willing to put up with these risks, just have no one to go to at this stage. Because in rural areas, in red states, there are no providers left. They're too afraid to practice, and it creates this incredible burden on the healthcare systems that exist for everybody involved.
That is such an incredible point. And I, when we talk about the impacts of criminalization, this feels like a layer we never talk about. That one of the impacts of criminalization is just how it decimates not just the provision of care to criminalized people, but decimates care overall. That's such a powerful point. Thank you for offering that. And one last question before we open it up. We'll probably have time for one audience question. But Indigo, to kind of build on that, I would love for you to talk about how criminalization isn't just about that behavior, but about so many of the things kind of surrounding it. And whether we're talking about, third-party laws with sex workers, or provision of care to people seeking abortions, or harm reduction, distribution, and possession of supplies. I would love to hear how that impacts your work.
Yeah, I think and reflect back to some of the big truths that Charles dropped about how criminalization is not just what's on paper, but it's this entire system that is targeting certain bodies and certain people, certain behaviors that are in a very in a very fascist sense, identifying who does not belong in society or the community and targeting to work against them. And we see in navigating both the on paper criminalization and the de facto systems of criminalization, a lot of really unnecessary tap dancing going on our end to look presentable on paper and in accordance with a lot of these very at best misguided laws and statutes, at worst and more so the reality of the situation, just violent. So some examples that I see in my work are how a lot of, as I mentioned before, a lot of the preventative kind of harm reduction, relationship-based community building work that we do at MoHo is about sharing information on how to do what you got to do in a safer and healthier way. But that can also be, in a different light, described as promoting prostitution. And so we have to be very careful about framing things in a very mild and sort of taking all the whorishness out of it, to make it not a target on the organization or the collective's backs, to be able to get this information out there. But then on the other hand, by obscuring it under all these different layers of either coded language or framing it in a different way, we actually sometimes end up making that information or those interventions less accessible to the people who need it most. On the end of how our harm reduction supplies distribution during outreach is impacted by laws that criminalize things like syringe exchange, or more broadly, like paraphernalia and giving other people paraphernalia. That's a great instance in my local context of this kind of discrepancy between what de facto criminalization looks like versus what's on paper, because of what's on paper and the criminalization of giving somebody a unused syringe that is way more safe to use than something that they've found outside. We all know that's a positive intervention, but very few people are going to do it because of these on paper laws that criminalize it, despite this kind of awareness by local policing organization, and just B cops know what's going on, and with our community presence and the people that we serve, people know what's going on, but there's also sort of a willingness to let things slide because of existing relationship and community building. We also see a lot of people shy away from that and not do the thing that they know the people that they serve and claim to be putting at the front of their work really need. Doesn't happen because of the on paper of the criminalization. Similarly, like condoms might be used to criminalize people. It's not illegal to hold a condom. It's not illegal to give somebody a condom. But we've also seen that, like, ultimately the issue is not like having the syringe or having the condom, it's who's holding it. And that there are really creative solutions that people who are practicing in this field can come up with to do the harm reduction for themselves and their communities through relationship building, through more public education and awareness to combat some of the NIMBYism of like people calling the cops to do these drug sweeps, to do these sweeps of known strolls and tracks. But it just requires extra steps, extra preventative measures, extra intention of actually building relationship with communities and coming up with creative solutions. So everybody who needs to know what's going on and everybody who doesn't need to know what's going on doesn't need to know and doesn't need to stick their neck in it. And that's like a thing that I really would like to encourage as somebody who for some time was like practicing within the institution and a lot of like by the book mindsets, is that like criminalization on paper there is a thing and it's not great, but there's like ways we can do what we want to do anyways. And this is not me going on the Zoom and publicly encouraging you all to go do crimes, because that probably will blow back on everybody in some way, but it is encouraging that just not being so fearful of like every single line shutting down our imagination of what could be, because the powers that be don't want a lot of the people in our communities to be. But ultimately, like, we're caregivers, not cops, and we can wear that hat and find creative non-carceral solutions to operate in a carceral state.
That was a beautiful note to end on. And I apologize, I absolutely lied. We are not going to have time for Q&A today. I apologize. But I hope that there were so many beautiful threads that came out today about how criminalization is really, it's undermining our ability to provide care and to provide care to the people who need it most. It is absolutely, criminalization is a process of really denying survival to specific bodies. It is not about the law on paper. It is about the way that it is played out, and that practice is a racialized and a gendered practice. It is that criminalization moves through these different networks that we hope are offering care to people and are unfortunately hamstrung by them. And that Mahathi, as was saying, you know, it compromises in the end care for all of us. It compromises the ability to live in the way that we want. And as Indigo shared, really that we have to be creative. We have to find the ingenuity that communities are already experiencing and accessing and proliferating if we're going to move around this. And as Charles has encouraged all of us to do, to be the most thoughtful accomplices that we can be in trying to make change. And I want to thank our incredible panelists. You guys, this is such a wonderful conversation. I'm genuinely sad that we have to wrap. I want to thank all of you for being here. I want to thank the audience, and I will hand it over to Alika to close us out.
Yeah, thank you, Kate and Charles and Mahathi and Indigo for being here today and being part of this panel. Really just appreciated hearing you all talk and speak to strategies to push back on criminalization. And just for some follow-up. I will send out the recording and any slides for both this webinar and the first webinar that we had in the series. And if you have any questions, feel free to reach out to NASTAD or Reframe, and we can funnel it to the correct person. But thank you all for being here today, and hope you have a lovely Thursday evening.